Okay, welcome back everybody from our short break. We have several more lightning poster presentations. I hope that you find it interesting to get a little quick snapshot of some of the research being done. Again, you can access the posters within the portal as well. So we're going to jump right in. Also, please be sure to use the Q&A function and enter your questions in the chat. Particularly want questions from community members, trainees, students. I know it can be challenging in these quick hit presentations, but please post your questions in the chat. Thank you, and we'll take it away.
Welcome to my poster entitled Functional Variation in the Heptoglobin Gene Affects Risk of Neurocognitive Impairment in People with HIV During Aging. In humans, the gene heptoglobin, HP, has a functional variation that involves the repeating of two tandem exons. HP1, which is the deletion allele, has one copy of exons 3 and 4, while HP2, which is the reference allele, has another copy of the two exons, being exons 5 and 6. In our study, we hypothesized that this HP variation associates with neurocognitive impairment, NCI, measured by the Global Deficit Score, GDS, in people with HIV. To assess that, we imputed the HP variation for the African and European descent participants of the CNS HIV antiretroviral therapy effects research, also known as the Charter study, and associated the variation with the GDS and NCI. We used a generalized estimating equations model with the first-degree autoregressive covariance structure to examine the effect of HP variation on the trajectory of change of GDS over age. In both the African and European descent participants, the GDS of HP2 individuals is higher than people without HP2, while a negative coefficient estimate for the interaction term between HP2 and age suggests that the GDS may slightly reduce during aging in HP2 individuals. Thank you.
Good afternoon. My name's Heather Derry. I'm a postdoc at Weill Cornell Medicine, and we recently conducted a cross-sectional analysis focused on predictors of inflammation, which is associated with poor health outcomes among those aging with HIV. In the behavioral literature, adverse childhood experiences, including severe stressors like abuse and neglect, have been linked to immune dysregulation across the lifespan. For example, when confronted with additional stressors, those with a history of childhood trauma tend to have larger or dysregulated responses and repercussions. This led us to ask whether a history of childhood trauma might amplify the link between disease burden and inflammation. We examined data from older adults receiving HIV care at Weill Cornell Medicine who had completed the ROA 2.0 survey and answered 2 questions about a history of childhood sexual abuse. Medical charts were reviewed in order to calculate VAX index scores, a measure of disease burden and multimorbidity, and participants attended a biomedical visit where they provided blood samples that were later assayed for inflammation markers. We were particularly interested in the interaction between childhood trauma history and disease burden in predicting inflammation. What we found was that 40% of the sample reported experiencing childhood sexual abuse, and that there was a significant interaction in predicting cytokine levels, such that those in the orange line with a childhood trauma history had a significant relationship between VAX score and cytokine levels, whereas those who did not have a childhood trauma history did not have a significant relationship. In addition, at higher disease burden, those that had a childhood trauma history had higher cytokine levels than those without this history. This suggests that the link between VAX score and inflammation might be amplified among those with a childhood trauma history. And among older adults with HIV, a childhood trauma history might indicate a higher inflammation risk, as well as potentially a greater need for or benefit from interventions that address inflammation processes. Thank you.
Hello, everyone, and welcome to the session. I am Dr. Hasina Kassem. A study of neurocognitive performance in women living with and without HIV in South Africa. HIV can cause both accelerated as well as accentuated aging, and this can occur regardless of whether or not you are on treatment. Even patients with high CD4 counts are not immune. Neurocognitive data from people living with HIV and receiving antiretroviral therapy and their HIV negative counterparts are lacking. In this cross-sectional study, we investigated the neurocognitive performance of women living with HIV who were on the PROMOTE cohort study at PHRU, as well as an age-matched comparison group of HIV uninfected women who were recruited from the same community. Our aim was to evaluate the prevalence of neurocognitive impairment and to describe the associated risk factors. In-depth neuropsychological testing was administered for the domains affected by HAN. We also assessed for depression, alcohol use, and functional impairment. What we found was that women living with HIV had higher impairment in 4 of the 6 domains tested compared to HIV uninfected women. However, despite this, the number of women diagnosed with mild or major neurocognitive disorder was similar between the groups. Additionally, women greater than 35 years of age and those with a lower ability to read had a higher frequency for neurocognitive disorder, irrespective of HIV status. One of the limitations in this study is that the tests that we used to assess neurocognitive performance were designed in a population different to ours. Another limitation would be that we are looking at cross-sectional data, and therefore we cannot infer causality, we can only look at associations. Having said that, the strength of the study lies in the fact that this study has the benefit of an HIV negative comparison group. Neurocognitive functioning remains an important clinical concern as it has implications for functioning, parenting, as well as ART adherence. Thank you.
Hello, this is Annie Nguyen presenting on behalf of the authorship team. Our poster is titled The Impact of COVID-19 on Health-Seeking Behaviors Among Older Adults Living with HIV in the Coachella Valley, California. The idea for our study germinated during the COVID-19 lockdowns. On March 19, California declared a statewide shelter-in-place order, and our team was concerned with how these mitigation measures would impact stress and isolation for older adults living with HIV. And we saw a need to document the impact of COVID-19 on people's lives. One, so that we could share findings with local providers who may be able to respond quickly in terms of providing services, but also, two, so that we can gain some insight into emergency preparedness for this group and what we might need to do in order to prepare for the next pandemic. We distributed electronic surveys to older adults ages 50 or older living with HIV in the Coachella Valley from the end of April to July. We surveyed 100 people. Half of the participants reported missing healthcare appointments during COVID-19. 35 people received mental health care before COVID-19, and 71% of them had their care interrupted during COVID-19. A quarter missed a dose of their HIV medications during COVID-19, and all listed forgot as the reason for skipping a dose. And finally, in bivariate analyses, people who experienced interruptions to their mental health care were significantly more likely to miss a dose of HIV medications.
Hello, my name is Stephanie Ruderman and I'm from the University of Washington presenting a study on frailty in people living with HIV. Frailty, which is generally associated with aging, is a syndrome comprised of physical components including fatigue, weight loss, low physical activity, low mobility, and grip strength. These symptoms have been observed among younger people living with HIV in the recent era of HIV treatment. We conducted a cross-sectional study on the presence of frailty measured by 4 of the 5 components of Fried's frailty phenotype and assessed associations between frailty and demographic, clinical, and socio-behavioral characteristics. Our study cohort included participants within the Centers for AIDS Research Network of Integrated Clinical Systems, or CENIX cohort, who completed an assessment of and measures between 2019. We used multi-risk regression models in our analyses with 3 levels of frailty, not frail, at risk for frailty, and frail. In our study population of 12,714 people living with HIV, 12% were frail and 42% were at risk for frailty. Some notable findings from our demographics and comorbidities model include that men who have sex with men were less likely to present with components of frailty. Also, those who have hepatitis C co-infection and depression as measured by PHQ-9 were more likely to present with components of frailty. From our substance use models, current methamphetamine, cigarette, illicit opioid, cocaine, and marijuana use were associated with presenting with components of frailty. Finally, people living with HIV who currently use alcohol were less likely to be frail, but former heavy drinkers who no longer drink were not. In conclusion, we identified important associations between frailty and common characteristics among people living with HIV. Further investigation into frailty is warranted, particularly in longitudinal studies that look into the temporality of these associations and the impact of changes in substance use.
Okay, wonderful quick presentations again. Thank you very much to all of our presenters who are here live to answer questions that we've received in the chat. So the first question comes from Jules Levin and is for Dr. Bush. And Jules writes that some aging older people with HIV do not appear to experience premature comorbidities, at least not yet. And perhaps it's just delayed. So he asks, are genetic markers associated with premature aging and immunosenescence?
We haven't examined explicitly any markers of premature aging or immunosenescence in the current study, but that is an excellent suggestion. One of the things that we do note is that the age effect appears to be different by race of our heptoglobin mutations, and so we do think that it is kind of an appealing hypothesis that somehow these alleles are sort of altering the aging trajectory.
Okay, thank you. And Dr. Derry, there are a couple questions here for you from Dr. Erlandson. She asks, was the cohort selected for childhood trauma? 40% who received childhood sexual trauma is quite striking. Heather, I think you may be frozen for a second. I'm going to move on. We can hear you.
The cohort was not selected for childhood trauma, and I agree. The number is quite striking.
And then the second question was, how were multiple indicators of inflammation combined? That's from Dr. Latender. Also for you, Dr. Derry.
Yes, we created a composite score of the cytokines that were measured, IL-6, TNF-alpha, and interferon gamma, because those were highly related as a composite score, and we also analyzed CRP data separately from that composite score. So what I presented was on the cytokine data, and we did not see the same pattern with CRP.
Okay, great. I'm going to defer the other questions for now, just so each presenter has a chance to answer. Dr. Nguyen and Mr. Taylor are here to answer questions about the COVID-19. Question was, should we be doing more to support people with HIV during COVID-19? If so, what? So Jeff, I'll throw that to you.
Sure, thank you. Short answer is yes. We didn't have room for everything on the poster, but some of the qualitative data, the responses we got back were that people knew what to do because they'd been through a pandemic before. So in some ways, they were better able to cope with it than others. We hear this anecdotally from providers as well. But as this drags on, people are telling us that they are feeling very isolated. The disruption to their mental health care, especially, is distressing to them. And we are planning a larger study comparing positive versus negative people living with HIV as the crisis continues to see if there are differences.
Okay, great. Thank you. Annie, anything to add there?
Just add briefly that we, telemedicine is expanding in many ways in terms of reimbursements and usage and all of that. But there's sort of different rates of uptake of telemedicine and how popular that may be with our population of older adults living with HIV, not just because of age, but socioeconomic issues as well. So, finding different ways to deliver mental health care will be important, not just relying on technology.
Agreed. Need to serve everybody. Dr. Kasim, can you talk a little bit about what might be the causes of the neurocognitive impairment in your control group? Because that was somewhat surprising.
Well, the control group did not show as high a rate as the HIV infected group did.
Okay.
So on all the tests, we actually found a higher rate in the HIV infected group.
Okay, great. Thank you. And let's see, Ms. Rudderman, a question in the chat. Did you distinguish between untreated and those cured of HCV?
No, we did not.
Okay. And then another question that says that several cohorts have found evidence of pre-frailty in HALO and Charter, but with frailty less common. Why do you think you saw more frailty in CNIX than those cohorts have shown?
We did find more pre-frailty compared to frailty. I'm not sure if maybe our numbers were different, but relative to each other in CNIX, there was 42% pre-frailty and 12% frailty.
Okay. Yeah, so it seems that pre-frailty across cohorts then is more common than frailty, full frailty. Okay. And then let's see here. That's a repeat of a question. And then there's one more. So, okay, that looks like them. I'm going to go back real quickly to Dr. Deary. So did you assess stress to see if history of trauma in childhood translated to worse stress in adulthood?
That's a great question. So this was a secondary analysis of some data that had been previously collected. We didn't have a specific that there are some psychosocial factors in adulthood that might be affected. So one way that I've tried to kind of parse that out is just by looking at rates of things like depression and loneliness. And I did not see significant differences based on childhood trauma history there. And when I entered those as covariates, they didn't affect the results. So it suggests to me that there might be some other processes going on as well, but that is a common pathway that we might think about for these results.
And were there specific components of the VAX that were associated with either inflammation or childhood trauma, or have you examined that yet?
I did not examine that. That's a great question, though. Thank you.
Okay, wonderful. And I think, so it sounds like that Dr. Ellenson is commenting that the frailty outcome is about 6 to 8% in other cohorts. So the 12% that you found in CNIX was a little higher for the frailty component. So, okay. And I invite the panelists, if they have any questions amongst each other, to ask them right now. We have maybe one more minute. Okay. I guess my question is for all of you, as a lot of these things we're talking about, frailty, loneliness, cognitive impairment, what are some of the kind of low-hanging fruit interventions that people would suggest that may help combat any of these things that we're seeing?
This is Jeff, and I'll jump in. For frailty, I think exercise, which is very hard to do and very hard to quantify, could be very expensive to set up, but I think that would be by and large, far away the best intervention we can provide people.
Great, thanks, Jeff.
Yeah, I'll chime in. I really agree with that, as well as other health behaviors that kind of hit on multiple processes. So for example, when you're talking about exercise, physical activity, smoking cessation, these are all health behaviors that are related to multiple of those outcomes. So those feel like, very potentially high impact behavior changes to target, in my opinion.
Great. Other thoughts? Okay. I'm getting questions about how hot it is in Palm Springs for Jeff right now. I know it's very hot where I am, and I'm much closer to the ocean than he is. So,
It's
Jeff,
a dry heat in the desert. Only when I wait Fahrenheit, so not bad.
108 is what Jeff's saying right now. So it's warm in Palm Springs. Okay. It seems like Heidi Crane is posting that CNICS's people with HIV in care across multiple sites rather than specifically enrolled for studies, so more of a clinically based population. And this may be one of the reasons we see higher rates of frailty in that population as compared to, say, Charter or other studies where people are specifically enrolling into a research study. So thank you, Heidi, for that comment. So I think that concludes our second lightning poster presentation. Thanks to all the presenters for your, again, coherent but quick presentations. And don't forget to check out their posters for more specific details. So that wraps our second lightning poster presentation. Thanks again. Okay, so that wraps our first day of the workshop. We will have more presentations tomorrow. We covered a broad range of topics today, starting out with pharmacology and then going into some talks, abstract-driven presentations, as well as our speed poster presentations. Covering, again, a wide range of topics. So tomorrow morning, we will start bright and early for some of us, earlier than we started today. And we hope to see you back then. I don't know if there are other housekeeping things that we have for now, but please log on. And I think the more discussion that we can get going in the chat, the better the workshop will be. So thank you to all of those who've been submitting questions. And again, I encourage people to continue to do that. So we will see you tomorrow, whatever time it is in your time zone. So check the portal for that. There is now a open forum that is for community and anyone else who wants to join, that is on the portal. You can log in. I believe it's a Zoom link to be able to facilitate discussion amongst community members. So please feel free to join that right now following this presentation. So thank you again for the first day and for engaging in our presentations. We'll see you tomorrow. And for those interested, again, join the community chat now. Thank you.